Hi, everyone, and I'd like to start by thanking the conference organizers for inviting us to present this abstract. These are my conflicts of interest. Let's delve right into the matter at hand. The hepatitis C prevalence in Canadian correctional facilities as of 2011 was that 1 in 4 inmates tested hepatitis C antibody positive both in federal and provincial prisons. That means that 1 in 4 has been previously exposed to hepatitis C. Specifically in Quebec, data in 2014 done by Michel Allaire found that approximately 12% of men and 20% of women were antibody positive, and you can see that the prevalence rates were upwards of 50% if the inmate endorsed injection drug use. Given that the general population in Canada has an antibody prevalence of approximately 8.8%, this means that the hepatitis C prevalence in Canadian corrections is approximately 40-fold higher than the general population. A major problem regarding treatment uptake in provincial and territorial custody, which is the focus of my talk, is the median time served in provincial and territorial prisons. As you can see here in light blue, 60% of inmates in provincial and territorial custody serve sentences of less than 1 month. Conversely, the remaining 40% serve sentences greater than 1 month. But to truly progress along the hepatitis C care cascade from diagnosis to treatment initiation, completion, and cure, you ideally need approximately 6 months of time, and that's restricting the population to only 10% of inmates, which makes it very challenging to engage these individuals in care during incarceration. So we are probably all familiar with the hepatitis C care cascade, which describes successive healthcare steps specific to hepatitis C infection, from diagnosis to confirmation with RNA testing, to linkage to care, to treatment initiation, completion, and cure, that result in optimal healthcare outcomes. The hepatitis C care cascade itself has rarely been studied among inmate populations globally and never among people in Canadian correctional facilities. I think it's important that we are all on the same page regarding challenges about engagement of hepatitis C care for provincial and territorial inmates. And this will sort of set the tone of my presentation. With respect to screening, most provincial and territorial prisons require on-demand screening for hepatitis C. That means that the inmate himself or herself must initiate or request the hepatitis C test. Most perform the antibody test via venipuncture, and this requires venous access, which may or may not be problematic. The average turnaround times are 24 to 48 hours, and if you have the luxury of having a provincial prison with a dedicated STBBI nursing support team, then this actually gets done, which is not the case in the majority of provincial and territorial prisons. With confirmatory testing, a second visit is required, and then a third visit is required to actually receive the results. And if anyone's ever worked in prison settings, there's challenges with inmate movement. Similar issues with venipuncture and venous access. And in Quebec, recent work that I did looked at the turnaround times of the hepatitis C RNA, and it ranged from 14 to 28 days. As I mentioned, the median sentence time is less than 1 month. So some of these inmates are actually not even receiving their confirmatory testing. With respect to linkage to care, it's rare that there are any on-site Hep C trained physicians, and therefore oftentimes liver disease assessments are done off-site, requiring transportation of the inmate to a Hep C care provider. Similarly, there's absent post-release follow-up, so in the event that they were not assessed during incarceration, we're not sure if they ever really get assessed once they're released. Finally, with respect to treatment, there are limited budgets in most provincial and territorial prisons where PCPA pricing does not exist for a reason that still is unclear to me, making treatments very, very expensive. In provincial and territorial prisons, particularly in Quebec, since I'm most familiar here, this is reserved for individuals who serve at least a 12-week sentence. And similarly to linkage, there is absent post-release follow-up for treatment. So even if an inmate warrants treatment and has a scheduled hepatitis C care provider, there is rarely any post-release follow-up that is done to ensure that this has occurred. And along the entire cascade, we have to keep in mind the short sentences, that there are high transfer and turnover rates that affect engagement in care, and then unscheduled releases. So the objective of our study was to characterize the hepatitis C cascade of care among people in Quebec's largest provincial prison, l'Établissement de détention de Montréal. EDM is, as I mentioned, the largest prison with a maximum capacity of approximately 1,400 male inmates. We included all inmates who made an initial on-demand request for hepatitis C screening between July 1st, 2017 and June 30th, 2018 over a 1-year period. All laboratory data needed to construct the hepatitis C care cascade was obtained from Sacré-Cœur Hospital, where all the blood work is sent. As this was aggregate data, there is a dedicated STBBI nursing team, fortunately, at EDM. They were provided with non-nominal identifiers to subsequently determine linkage, treatment initiation, and SVR rates using the prison health records. So we conceptualize the cascade of care as a continuum of 8 steps. First, total sentenced inmates. Second, those who were screened for Hep C. Remember, this is by on-demand screening. Those who were antibody positive, RNA tested, confirmed chronic hepatitis C, who were linked to care, no on-site care provider at Bordeaux or EDM. So these are the number who were assessed by an off-site hepatitis C care provider, who were initiated on treatment. These were done on-site, and then who subsequently achieved SVR 12. In terms of our statistical analysis, we calculated the proportion of inmates at each step of the care cascade using denominator-numerator linkage, so the diagram on the bottom, whereby data is linked at the individual level within each step. We then subsequently calculated the proportion screened, i.e. in step 2, among inmates who were sentenced for at least 1 month, which I showed you initially was estimated to be 40% of the total sentenced inmate population, during which time we felt that screening should be feasible. So let's look at our results. Because this was aggregate data, we have no baseline patient characteristics other than they were all male and the median age was 35 years of age. So this is our cascade of care, and I'd like to pay your attention to the y-axis and notice there's a break between 400 and 5,000. So among the approximate 5,000 sentenced inmates between the 1-year period, 344 were requested on-demand screening, which represents 7% of the sentenced population. Among these, 38 were antibody positive, or 11%, which confirms work by Michel Allary in the province. Among those who were antibody tested, 35 out of 38 underwent testing, 92%, among whom 16 out of 35, or 46%, were RNA positive. 10 out of 16, or 63%, were linked to care. Only 3 were initiated on treatment, and 2 achieved SVR. This is over a 1-year period. Now, when we look at those who were lost to follow-up, 6, as I mentioned, 6 were not linked to care, 3 refused, and 3 were released prior to being assessed by a healthcare provider. Among the 7 who were not on treatment, 3 had short sentences and therefore did not qualify for treatment. 2 refused, 1 was transferred, and 1 passed away due to a non-hepatitis C-related event. And the 1 that was not cured had not reached the SVR time point. Now, if we restrict the analysis to inmates sentenced for at least 1 month, our N now becomes 1972, and this brings our total screen population from 7 to 17%. The remainder of the cascade is identical. Let's talk about some study limitations. First of all, there is no formal post-release follow-up procedures that are currently in place at EDM, which means that it's possible that we underestimated the true proportion of inmates who were linked to care, initiated on treatment, and achieved SVR. Secondly, an important consideration to take into account with future work that I do in this area is that the sentence duration was unknown. And so we may again have underestimated the proportion who progressed along the hepatitis C care cascade simply due to short incarcerations. So it will be important to dissect the cascade depending on sentence durations in the future. And finally, because this was aggregate data, we were not able to better understand progression or lack thereof along the hepatitis C care cascade with respect to patient characteristics. So to conclude, this is the first study assessing the hepatitis C care cascade in a Canadian provincial prison, and it's likely generalizable to other provincial prisons who have on-demand Hep C screening. It was very obvious that the major bottleneck for engagement in hepatitis C care for people incarcerated in ODM is screening. Only 7% of sentenced inmates during a one-year period requested Hep C screening. I do think that one of the advantages at ODM is that they do have a dedicated nursing team, and subsequently the majority, 92% of inmates underwent appropriate hepatitis C RNA testing. So this is a definite plus, and it's in keeping with a recent systematic literature review that we conducted that found that on-site Hep C testing with nurse-led education and counseling had the greatest impact on hepatitis C screening rates. We found very low linkage and treatment uptake rates in 1 year due to refusals, short sentences, and prison transfers. These are challenges that we will all have to accept if we're to work in provincial prison settings. But this was primarily driven by the fact that screening rates were extremely low. So going forward, I hope this study, the work from this study helps to advocate for the adoption of, first and foremost, if I could do anything and change anything, it would be to advocate for the adoption of systematic opt-out screening at the time of admission. We also hope that this work reinforces the importance of having a dedicated nursing staff who are trained in STBBI screening and care in all provincial and territorial prisons. We hope this reinforces that hepatitis C education programs for anyone working on site is made available, primarily because this will reduce the need to link to an off-site care provider and decrease time to each step along the care cascade. Importantly as well, hopefully we can learn to formalize post-release follow-up procedures and perform qualitative studies to better understand why there are refusals in the hepatitis C care engagement in prison settings. And I'd like to just finish by saying Canada will fail to eliminate hepatitis C if it continues to neglect its provincial and territorial prison populations. And with that, I'd like to acknowledge all the personnel at Sacré-Cœur Hospital, our wonderful nurses at ODM, and I'd be happy to take any of your questions.
Thank you, Nadine. We have time for one or two questions, please.
Yes.
Can you hear me? Okay. I noticed this whole study was for inmates that were sentenced, and I was just wondering, how do we reach the inmates that are on remand, and what do you think your data would have shown if you studied people who were on remand?
Okay, good question. I'm surprised anyone knows about it. So remand, for people who don't know, are individuals who are awaiting sentencing. And most of these individuals are actually transferred or released within 24 to 48 hours of admission. So this is, you think this is a challenging population, the remand population, given that they're there for an extremely short window of time. The only thing that I can feasibly see is systematic opt-out screening upon admission with potentially linkage to care thereafter for follow-up of results. But a super challenging population that I have neglected to study to date, given how challenging it is even with the sentence population. But thanks for that very important question.
Yeah, thank you, Nadine. It was a very nice presentation. I have a question. The 7% patients who were screened is very low, as you pointed out nicely. So, and you mentioned about education. So in the prisons, for my knowledge, is there any education, pre-screening education, like mention about hepatitis C to all patients who are inmates? Because I understand there is post-education, so post-screening education, but what about pre-screening? Is there any education about the frequency of the disease in prisons so that the inmates know about the existence of the disease and that they are at higher risk than the general population?
Thank you, Jada, for that important question. This is not systematically done. I can only comment about ODM, and there are weekly sort of 1 to 2 hour entire holistic health care sessions that not necessarily target hepatitis C, but hepatitis C is mentioned. I know Laurence from CAPAC is working in some of the provincial prisons to bring an educational volet to provincial prisons, but there is nothing that's systematically done.
Yeah, just one last.
Hi, Lindsay.
Okay, how are you?
Good, you?
Good. Okay, just 2 really quick questions. I know you said 1, but I got 2. So the first one is actually just kind of in response to your comment around the remand. So in Ontario, a big pattern is not 24 to 48 hours of people being in remand. We have people sitting in remand for 2, 3, 6 years.
Oh, wow.
Waiting on trial, waiting on bails, sitting in immigration hold when their sentences are done and they're still on immigration hold within our jails.
Wow.
So I think it would be great to be able to have further research for that remand population, because we also know that's the revolving door of in and out into the community. And we also know that it's also a direct reflection into drug use as well as the overdose crisis that we have right now as well, right? So I think the remand population is sometimes just kind of pushed aside because of this so-called 24, 48 hours or 7 days of this median. But there are plenty of people inside that are spending years under remand. And just one question. Can you just expand on your advocacy around the opt-out screening? Because I think that just kind of takes people's choice away to get screened. So can you just expand on maybe how you would be advocating to make me change my mind around taking away somebody's choice?
Okay, so my thank you for your first comment. So we will maybe partner up and do some work in the remand population. The reason why I personally advocate for systematic opt-out testing is that it's based on the evidence. So studies in the States have shown simply that if you offer opt-out versus opt-in versus risk-based versus on-demand, the screening rates are higher. And so to try to capture more individuals, that is the main argument for opt-out screening. That said, I don't believe that your explanation or the way you phrased it, that it's actually you've taken away someone's choice, I don't believe that that's accurate. The way opt-out should be presented is that this is the screening test that is currently being offered, and you have the choice to opt out of the screening test. So there's always a choice when it is presented appropriately, in my opinion.